Good morning, everybody. Can everybody hear me? Yeah? Okay. It's good to see many of you. When we have worked together, I'm in this town for many years and have worked in various settings and worked with many of you over these years. And it's a pleasure to see you this morning. So we're going to talk today about what we call dementia for many years. And now with the DSM-5, we call it neurocognitive disorder. But it's basically a major neurocognitive disorder. So let me ask anyone in this room who had ever worked with dementia, or let me ask the other way around. So anybody in the room who has never worked with a patient with a dementia, or either have taken care of some family member or a friend, so look like everybody, right? So no, all of us have experience. So let's go it together. What we know and where the field is going. So dementia, this was a term which has been used for many years, and even for historical purpose, it's still in the DSM-5. It's not totally eliminated, but it's kept for historical reason. But it is changed. The new is major neurocognitive disorder. That's the terminology. And the rationale behind it, if you look at the dementia, so what it brings to the mind, dementia? Somebody who is old, somebody, who has Alzheimer. That's basically most of the people will think about it. But nowadays, we are seeing dementia in very young people. And so what's the reason for the dementia in the young people? Can be trauma. Sometimes it's a substance abuse. And patients, after substance abuse, they have hypoxia. And that can cause some damage to the neurons and can cause. So let's say somebody who is having all these symptoms when they are just in their 20s, and you call them demented, so it's not a correct term anymore. So that is the push behind it to rename it as a major neurocognitive disorder. So we'll talk about that. So what we're going to talk about is what is the DSM-5 neurocognitive disorder and what types of these major neurocognitive disorders are in DSM-5. And we're going to talk about the neurobiology of major neurocognitive disorder, but basically we'll discuss about the Alzheimer. Still, that is the majority of the patients you're going to deal with dementia. And what are the new criteria and the guidelines where we are going for the Alzheimer disease? And we will talk about the evidence-based treatments for Alzheimer. So if you take a look at this diagram, all of us, basically our memory was the best when we were just 20-year-old. Okay. So this is what happened after 20s. You see, even when you are 30, it starts to come down, right? And it will keep going down like this. But what happened is the person who has what we call dementia, they start to decline rapidly after the 50s and the 60s. So that's what we will be talking about as we discuss about the Alzheimer. So if you look at the dementia, which we call now neurocognitive disorder, if you look at the people below 65, what is the prevalence of the dementia or the major neurocognitive disorder in people less than 65? Let's talk about between 60 and 65. What is the prevalence of that? Anybody knows? It's 1%. Okay. But see what happened after the 65. After 65, every 5 years it's going to double. So after 65, if you look at the prevalences, 5 to 10% of those between the age of 65 and 74. So above 65, there are 5% people has dementia. And after that, every 5 years, it becomes double than that. So people above the age of 85, there is 40% have dementia. So it's a large number. And the way the population is growing, in the worldwide, in the 2030, there will be more than 30 million, and 2040, more than 60 million people have dementia. And so that's a large number of the population all over the world have dementia. So if you look at the nursing home admission, 50% of the patients who go there have dementia that lead to the admission to the nursing home. So in the United States, 5 million people at the present time have been diagnosed with dementia. And in DSM-5, this term is only retained for historical continuity. Otherwise, it's changed. So neurocognitive disorder is the preferred terminology. And mainly, it's, as we talked before, we are seeing more impairment which are secondary to the other condition in the young individuals. TBI is one of them. So why we call it neurocognitive disorder? The biggest part is the cognitive deficits. We see the cognitive deficits also in patients who have schizophrenia and patients who have major depression. As you know, some of them have the difficulty with the attention, concentration. And in the schizophrenia, schizoaffective, if you look at the positive symptoms, negative symptoms, there are cognitive symptoms. So, but in patients with a neurocognitive disorder, cognitive deficits are present in many, but the core feature of the neurocognitive disorder is the cognitive deficits. And in this, it's not from the birth. If it's from the birth, then we look at the intellectual disabilities. So the person have achieved the intelligence, and from that, it is a decline further in the neurocognitive disorders. And it's a decline from the previously attained level of functioning. And in the DSM-5, neurocognitive disorder are, after delirium, it will be the major neurocognitive disorder and the mild neurocognitive disorder. That's the terminology for that. And we will go through these symptoms as we go through all this. And we already talked about main thing is significant decline from the previous level of cognitive functioning. And what is the cognitive functioning? There are domains in that. And those domains are the attention, executive functioning, memory, language, motor abilities, and social skills. So these are the domains in which there is impairment. It can be in one area, two area, or in the all 6 areas. But for the major neurocognitive disorder, we need to have more than 2. Okay. And sometimes the patient will complain themselves that their memory is not as good as it used to be, or they are having some impairment to carry on some of the tasks, or it might be somebody who is the caregiver or family member who will complain about that. Or the clinician might look at that and say, you have some of the impairment in this area. So that is the first part of it in the diagnosis. There is a cognitive decline based on these domains. And first is the complaints. The second part is based on the test, that you will see there is impairment in these areas. Okay. So, and then the third part is these deficits, they are causing the impairment in daily activities, activities of daily living. And those can be like one cannot pay the bills anymore, okay? Cannot plan for the day, or it takes a long time to carry on what they were planning to do. The things which were so simple for them to do, now it takes ever. Okay? And these are not only in delirium, and they are not part of any other diagnosis. Okay. So that is the diagnostic criteria for the neurocognitive disorder. In the mild, it's the same thing, but see if the major is there is significant decline, and then the mild is it's a modest decline from the previous level of cognitive functioning. And again, it's the same thing which we talked before. Same 6 domains: attention, executive functioning, memory, language, motor abilities, social skills. And it's the same, the complaint by the individual, family members, or somebody know, or the clinician. The testing and the impairment in the daily activities, not in the presence of delirium and not part of any other diagnosis. So the only part is, there is some criticism on that. It is basically on a continuum. Okay. As we go on through this, that's what we will see. But the DSM-5 made the attempt. Okay. So in the past, sometimes we call it like a mild cognitive impairment. Remember that was some term MCI. And now it's a mild neurocognitive disorders in DSM-5. So what are the types of neurocognitive disorder? They will be like this. Both types, major and mild, will say neurocognitive disorder due to Alzheimer's disease, or neurocognitive disorder due to the vascular disease. Okay? Neurocognitive disorder due to the Lewy body, that's Lewy body dementia, which we used to call it. So it's neurocognitive disorder due to Lewy bodies. Neurocognitive disorder due to the Parkinson's disease, or neurocognitive disorder due to the frontotemporal lobar degeneration, and neurocognitive disorder due to traumatic brain injury, or NCD due to HIV infection, or NCD due to substance-induced medication. So the diagnosis will be, let's say somebody has Alzheimer's disease, so you have to diagnose like that, major neurocognitive disorder or a mild neurocognitive disorder due to Alzheimer's disease. Or if it's due to Parkinson's, it will be neurocognitive disorder, either major or mild, due to the Parkinson's disease. The other thing which can give rise to neurocognitive disorder, it's due to the Huntington disease or the prion disease. Anybody know what prion is? Prion, if you look at what can give rise to the infection, in the beginning we didn't know what prion is. We thought, is this a virus? Is this a bacteria? Or is this some other kind of infection? But basically what had happened is, in the neurons, there is a mechanism where the proteins are all formed, and then when the cells are not functioning, they are removed. So there is a built-in mechanism in the nervous system which remove the things which are not working. So that is it's like a pump which removes it. So what happens is, these proteins, they are formed all the time, and they have a particular shape. But sometimes they start to misfold. It's called misfolding proteins. And then they are not removed, and then they take their own way to create further problems. And that's what is part of the prion. Or any other medical condition can give rise to that. Or There can be multiple etiology. People can have Alzheimer's disease, they can have vascular dementia at the same time. Or if you can't find anything, or you don't know yet, you can say unspecified neurocognitive disorder. The one thing which DSM-5 changed as compared to DSM-4, remember in the past we used to have NOS. Okay. Like you can have in every category, like psychotic disorder, NOS, or depressive disorder, NOS. So the NOS in DSM-5 is totally removed. So in DSM-5, it's an unspecified terminology. So, yeah.
So in this one, if it wouldn't be NCD due to unspecified, we would just say unspecified NCD due
Right.
to moderate or mild.
Right,
Okay.
like that. So, right, it's not just a neurocognitive disorder, in whole DSM-5, even in depressive disorder, NOS, you won't say depressive disorder unspecified. You will say unspecified depressive disorder. Same thing in psychotic disorder, NOS, you will not say psychotic disorder unspecified, you will say unspecified psychotic disorder. That is the DSM-5 terminology. So the further, you have to specify further, and that will be, let's say, major neurocognitive disorder due to the Alzheimer's disease, then you have to specify with or without behavioral disturbance. Okay. If the person has a behavioral disturbance, then you will say with behavioral disturbance, and if they do not have any behavioral disturbance, you will say without behavioral disturbance. Anybody know what we mean when we say somebody with behavioral disturbance? What type of things come in behavioral disturbance? Combative behavior. Anybody else?
Running around the hospital nude.
Right. Yeah. Right. Okay. Wanderers. Right.
Aggressive, agitated,
Agitated.
threaten their loved ones,
Right.
harm things, destroy things.
Right. Anybody else?
Would non-stop talking fall in this category?
Can be. Right. Right. Anybody else? Wandering. Right. Anybody else? Anybody else?
What about the catatonia part? Is that complete?
Right. So basically, behavioral disturbance will include a person is psychotic, that will come under behavioral disturbance. Okay. If the person is depressed, that will come under behavioral disturbance. Right. If it is apathy or catatonia and all that, these are the part. There is no diagnosis like in DSM-5 with psychotic symptom, without psychotic symptom, or with a depressive symptom. It is all part of this behavioral disturbance. So major neurocognitive disorder due to Alzheimer's disease, if you have all these things or any of those things, you will say with behavioral disturbance. Okay?
Does the mild, moderate, severe have to do with?
You have to specify about the Alzheimer's then. There's two specifiers, one at the beginning of NCD and then one after just specific things.
Right,
There's
right.
double, you have major neurocognitive
Right.
disorder due to Alzheimer's, moderate.
Right. And as we go further in this, you will see why it's that. Okay. So even though a person may have major neurocognitive, but they still may not have this whole severity of the impairment. So that is the reason there is another specifier, mild, moderate, and severe. The last specifier is this a probable or is this possible? Let's say the Alzheimer's disease. How do you diagnose somebody with Alzheimer? Definite. If you say somebody definitely has Alzheimer, how would you diagnose? Afterward. Postmortem. So does that help anybody? Right? So, that's the clinical pathological diagnosis after the patient has died, and in a post-mortem you remove the brain out, and then you look at these, plaques and all that. So it doesn't help that person.
Brain imaging doesn't show that at all.
That's what we will talk about it as we go along. That.
Well, not the post-mortem brain imaging, but while you're alive, they can do so much work now with brain imaging
Right.
and so forth.
That is where we are going into that. So the FDA has just approved. There are a couple of things they have approved for the amyloid imaging. So, but then there are specifiers like that. You will say probable or possible. So what are those cognitive domains, which we are talking about? These are the domains are one is the attention, which we call complex attention. And in this, we check somebody for their sustained attention, or selective attention, or divided attention. Anybody knows what's the difference between these? How would you test somebody with a sustained attention? Right. So, sustained attention is that your ability to stay focused on the task. And the task, in the testing wise, anybody psychologist here? Right. So you know better than, And the sustained attention is basically the focus. And the way you test is you give them one thing to look in the computer, let's say if there is something which will come on and you have to press a button. Okay. So in that way you remember that's what you have to do. And you are looking at that, and every time it comes, you have to, and then you look at the hit and miss, right? Something like that. So in a selective attention, anybody know what selective attention is? So it's like you are given, let's say you are given some letter and some numbers. They are coming to you, but you are asked to pick up only one of them. Right? Something like that. So let's say if there are number coming, at the same time some letter coming, but you have to ignore the letter, but you have to pick the number. Okay. So that is you are selectively paying attention to that. Divided attention is, anybody know?
Be having a task and paying attention to one thing and paying attention to another thing.
Right. Doing two things at the same time. So let's say you ask somebody like to keep tapping, and then asking them listening to the story and all, something like that. So you are paying attention to the two tasks. So there is impairment in that area, in the attention part. The second part is the executive functioning, and it has many things. You have to plan for something. Let's say when we are here, we are told there is an exit on this side, and if something happens, we need to go through the exit. So we need to plan for that, right? Or decision making. You are given two things to decide. You have to pick one of them. Working memory, that you have to hold something for a while. Okay. Or the feedback response, able to obtain the feedback and act on it. Error correction, inhibition. Inhibition is that you have to ignore certain things, something like that. Mental flexibility, you have the set of the mind to change. So then we check for the memory, immediate, recent, and remote. And those are the type things when we ask somebody to remember 3 words, and we will ask them a little bit later on. Okay. And so we look at the remote memory things that happened in the past. Then we look at the language part, the expressive, grammar, receptive. When we give somebody a little story and ask them to repeat it, right? And we are looking at whether they were able to receive it, then able to produce it. Okay. Then looking at the perceptual motor type of activities. Okay. And looking at the social cognition. In this we are looking at whether the person has the ability to recognize the emotion in the others. Okay. So all these areas ultimately have the impairment, and as you go from mild to severe, you will start to see more impairment in different areas, or in all of the areas in severe. So that's what we were talking a little bit earlier. Somebody who has a neurocognitive disorder can have this kind of thing aimlessly, as we were talking about the wandering or, those kind of things. Do we see this thing in patient who has, so it takes a long, it's a very slow thinking. Sometimes keep repeating the same thing. And then start developing the false ideas. Mostly they are very persecutory ideas. And if you see a patient with dementia, they will be accusing for various kind of things. Somebody stole my stuff. They misplace it and think somebody stole it. Somebody, looking at them, watching them, those kind of things. So,
them feeling that you are accusing them versus blaming you or blaming.
but if the person who has it,
Yes.
right.
Feeling that you say something to them and they feel that you are accusing them. Could it be the reverse of what you were saying?
Mostly it's the other way around, that somebody is, that's the persecutory type of stuff,
The reason I was asking that because I'm married to a person who has mild cognitive dysfunction, and with the possibility of Alzheimer's is what the diagnosis is. And the reason I asked earlier about the nonstop talking is he gets up in the morning and talks nonstop all day. He tells me the same thing over and over and over again.
Okay, that's what this perseveration is?
Yes.
Right, right. And as we will go through this,
Okay.
you will see, it depends upon what part of the brain is involved, where it's involved. Right, right. So it will come into all that. Ultimately, sometimes speech will become very incoherent and person become mute. So this is what we were talking about earlier. This behavioral part, the affective is the mood part, and the psychotic part, they accompany these cognitive deficits. And when they accompany that, we call it with behavioral disturbance. In the beginning, person has some insight, but then ultimately it's lost. Okay. Right in the beginning, person may say, I have some difficulties. Okay. And many times you're going to see depression, anxiety, person may be distressed, see irritability, and even you see aggression. And then this affect later on becomes blunted. And you can see hallucinations and the delusions then can come along with it. What type of hallucinations you see in the neurocognitive disorders?
Can I ask you a question?
Uh-huh.
I'm going to say something personal. My mother passed away in my house just short of her 94th birthday. Not going into too much detail. She gave me a hands-on, I worked a lot with these people. I don't have this experience that happened with living.
Right.
She was reliving early life experiences. I did not consider them hallucinations.
Right.
They were actual documented experiences he was living over. And that's what I've noticed in these folks.
Right.
Not only in that, but people who maybe are not diagnosed dementia, but are close to death.
Right.
They have these experiences.
Right.
And they would talk about earlier things that the relatives have come to them, they've seen them, etc. Can you kind of elaborate on that?
That's true. The hallucination is, if you look at the definition of hallucination, delusions, what it is. Delusion is false belief, right? And right. But false belief is based on that person's culture and society, which is not appropriate. the person you are dealing with a neurocognitive disorder, as they start to go back, their memory for the immediate events, for the recent events is gone. But for remote events, what they are talking about, as a child, you don't have any experience. You are not there. And they are talking about what they dealt with. The difficulty you have is when you take care of somebody with dementia, now you are a caregiver. You have to take care of their daily things. You may have to give them baths, you may have to take them to toilet, and now you are taking care of a child which was your parent. And for them, they are already becoming child. So their memory is there. So they think you are the parent, you are my father, or you are my mother. So then they start. Right. Right, supposed to, based on where they are at that time. And that's what you see sometimes. When they think your spouse, then it's a sexually inappropriate behavior sometimes you see. It's a daughter, and the father might think it's my spouse, and they want to engage in some sexual activity. Okay. And it can be very distressing and also unmanageable sometimes. Okay. Same thing is when they go back, the thing they are describing is, unless you pay attention to that, you may think it's a hallucination. It may not be hallucination. But it is, as we go into this, we'll talk a little bit more as we talk about the agnosia, apraxia, and those kind of things. It is, what they're seeing is, it's not connecting with the brain, what the brain is interpreting it. So that's what you say. But if you're going to see any hallucinations, what type of hallucinations you're going to see in neurocognitive disorders? Anybody? Visual. So mostly you're going to see visual hallucinations. It's the auditory hallucinations, those are like schizophrenia and schizophrenia. There are many people who have schizophrenia ultimately end up having, dementia or the neurocognitive disorder. And so they're auditory hallucinations, but majority of the time you are going to see visual hallucinations.
Standing at the end of the bed. I said, what did they say to you? Nothing. They just stare at you.
Right. And the delusions are basically persecutory type of delusions you're going to see in the neurocognitive disorders.
I'm a licensed mental health professional, and I'm getting old, and I've also worked with people with addiction. And I've had people tell me, they've had long-term, possibly psychosis due to methamphetamine, but they've actually seen people that are dead. And it's like, okay, hallucination, psychotic. But then again, the older I get, and I've been teaching psychology for 25 years, we're really beginning to recognize the sixth sense. I know to document that they said that they saw this, but in my heart, I'm beginning to think, well, maybe they really did. How do you differentiate?
That's exactly, Dr. Flora, that's what he said. Basically, how you distinguish a visual hallucination or their memory and their experience. Maybe they are talking about something when they had to deal with somebody who died. Okay. Right.
They really did get a visitation or something.
Well, again, as you go, then if your memories are right, and we can spend a lot of time with the confabulation type of thing, right? So it's a very interesting field, and we are learning more and more about it as we are dealing with this. But if you look at in the population which we are going to talk about, and that is looking at people above the age of 65, which majority of the time we're going to see with major neurocognitive disorder. And if you look at that, 50 to 75% who has that, they have Alzheimer's disease. And so that is the number one cause of major neurocognitive disorder in the elderly. Second one is the vascular dementia. And that we will talk a little bit about those. And then third one is the frontotemporal, and the fourth one is the Lewy body. And neurocognitive disorder of the Alzheimer type. So there are some biochemical issues in the brain, and these are the abnormal proteins. And we are going to talk a little bit more, but they are called amyloid plaques and neurofibrillary tangles. And as we already said, it's the leading cause of dementia, more than 65%. It's more in women. It's twice as common in women, mainly because they have longer life expectancy. So as compared to the other neurocognitive disorder, the people with Alzheimer's disease in the early stage are better groomed as compared to the other. The vascular disease, it's more common in men. And what you're going to see, the person has hypertension, they have hyperlipidemia, can have diabetes, can have smoking. Both vascular dementia and the Alzheimer's disease can coexist. In this, it's a gradual decline. TIA, have you heard the term TIA, transient ischemic attacks? And many times these give lacunar infarct. And that can happen in any part. And sometimes you will see some neurological damage, but sometimes you may not see neurologically, but accumulatively it starts to interfere with the cognitive domains. And it can be focal loss neurologically if you're going to see anything. And the person may be more aware that they're getting deficits as compared to the Alzheimer. Dementia with the Lewy bodies, it's the third most common dementia. And basically, what you have is the person has a symptom like Alzheimer's disease and have like a Parkinson's disease. Okay. And hallucinations are common, and many times they are visual hallucinations. And what you have is shorter memory here may be preserved a little bit longer. And as in Parkinsonism, person can have tremor and can have rigidity. Okay. So that's what we call neurocognitive disorder of the Lewy bodies. Then the frontal temporal degeneration. It used to be called PIC disease in the past, but now we call frontotemporal lobar degeneration. As we already talked, it's about 5 to 10% of the dementias. And usually the onset is a little younger. It's around 55 it can start. And as it affects the frontal lobe, you're going to see mostly the personality, and the temporal, you're going to see some of the language issues. This one? Can be. It's hereditary. And the behavior becomes disinhibited and repetitive. And many times you're going to see more disinhibitive type issues in the frontotemporal. So, go ahead.
Temporal, is that more treatable with medication than any other type?
They are neurodegenerative, and once it starts, it really causes a lot of problem down there. Right? It's more.
I was asking because one of my clients is a caretaker for.
Correct, right?
Yes.
So let's go with the Alzheimer's. That's the common one, and that's what we will talk about today. It's the leading cause of dementia or major neurocognitive disorder. And as we already talked about the cognitive domains, it causes the impairment in all of these areas. And in the beginning, it may be only one or two, but ultimately in all of them. Usually you're going to see between the age of 65 and 85, and as we already talked, the prevalence is going to double or every 5 years. Head injury in the younger people can lead to the dementia, and genetics has a role in Alzheimer's disease. Can. Yeah. But for the child, you have to attain, first you have to attain that intelligence. That's what we are talking about. But it can happen. It can happen early on. Okay. So these are the protective factors. Sometimes can help, and we'll talk about those a little bit. Why we say smoking can cut down some of the, or delay the dementias. Anybody have any clue about it? Right.
Really?
Right.
Nicotine?
Yeah. But that doesn't mean that we are recommending anybody to smoke, right? So what it is, actually there is a lot of research on the nicotine receptors. And the nicotine receptors, there are about 7 of them. It's the 7 receptor. If you can find something which act on that, can improve the cognition. Actually, there are many medicines which are being looked at this time, working on the nicotine receptor, which can help with the cognition, not just in these cognitive disorders, but also in patients with schizophrenia or patients who have impairment in the cognitive domains.
I have a question. I saw at the Eastern State Hospital big sign saying no smoking zone. And I remember when I was young and worked in one of those mental hospitals, that's all they did. And it seemed to give them a sense of stability and pleasure. Is there any chance they might allow them to smoke it?
No. Even if, when you came here, did you see our sign? Not in the building, on the whole campus. We don't allow it. It's basically the nicotine and smoking cause so much impairment, and it increase the morbidity, mortality. Who knows what it will do when somebody is 60-year-old, but if you smoke and you start developing all the other complications before that, and that can lead to the morbidity and mortality, that doesn't help anything. And so...
Talk a little bit more about the education. You read all these things about, say, work crossword puzzles and take a course in Spanish or French or whatever is supposed to delay that. Is there anything to that?
If you look at the overall studies, the people with low socioeconomic status and low education, you see higher incidence of dementia in that. And the people who have education, and the more education you have, and the more you keep up with that, you preserve the neurons better. And so that they cause, remember, these are, what we are talking about is basically cognitive domains. How you can preserve those cognitive domains. That's the way we are diagnosing somebody with major neurocognitive or mild, and people who have a better education retain better. And the more you practice, the better you are. The more you keep up with every day. When we go into later on in the prevention and the treatment, we'll talk a little bit about it. So this is the type of thing which we call, we're talking about probable and definite, and this is what you are looking at basically. In probable, you are looking at somebody between the age of 40 and, why we say 40? Some people have early onset of Alzheimer. And as we go into the gene, we will talk about it. So the dementia with the onset between the age of 40 and 90, and there is impairment in cognitive domains in 2 or more areas. And there is a progressive decline in the memory and the cognitive deterioration. And there is no other illness which account for it. And the consciousness is clear. There is no deterioration in that. So that is, if somebody has that, we can only say probable, right? The only way we can say definite is if the people have the clinical criteria at the autopsy, you have the histopathological change. And we will call it a clinico-pathological diagnosis. But this is the thing which is most important. This is where we are going. This is what the direction is. If you look at the biomarkers, and you are going to hear more and more about the biomarkers. Biomarker is somebody who has this major neurocognitive disorder, Alzheimer type, if you look at their cerebrospinal fluid, CSF, you're going to see their amyloid beta-protein, this is AB protein, its level declines, and the level of the tau and the phosphorylated tau level increase several years before even the onset of the Alzheimer dementia. So we are going to hear more about it. And this is the test you can do and look at the levels of these. The tau and the phosphorylated tau, dephosphorylated is what we require. Okay. You remember the neuron body and remember the axon which goes from that and the dendrites. And that axon, that whole filament, it's supported by this tau. Okay. And that is dephosphorylated tau. But if once it starts to become phosphorylated, then that part starts to degenerate. Okay. So the level of that increase. So that is one biomarker. The second biomarker is you can do the imaging. Actually, there are two chemicals which have been approved by the FDA. And with that, you can do the scans, and you will see the amyloid is deposited in the brain several years prior to the onset of dementia in Alzheimer's disease. And the third part is you can do the MRI, you can see the atrophy. Or you can do the PET scan, and you can see this hypometabolism on fluorodeoxyglucose in the PET scan. Or you can see hypoperfusion on the SPECT scan. So these are the biomarkers, but they are not specific to just the Alzheimer. This atrophy, hypometabolism, and the hypoperfusion. But if you have one of the other things along with it, you can say definitely this person has Alzheimer. Okay. So you see in the last biomarker, and you see one of the other biomarker along with the clinical signs, and you can say definitely this person has the Alzheimer. That's where we are going. And if we do this, we will have many people we can diagnose in a preclinical, even before they have the onset. We'll talk about it. So this NINCDS-ADRDA, what it is, this is National Institute of Neurological, Communicative Disorder, and Stroke. That is NINCDS. ADRDA is Alzheimer's disease and related disorders association. So these organizations are leading in this diagnostic categories and looking at that. There are some other organizations. One is the International Work Group, and one is the National Institute of Aging, along with the Alzheimer's Association, have given us the criteria. And this is the criteria we're looking at. So we already talked about if you follow this criteria, people who are between the age of 65 to 74, 3% of them they have it's a prevalence for the Alzheimer's disease. Remember we talked about 5% and above? That's all of the dementia. But for the Alzheimer, 3% in that. If you look at 75 to 84, you are looking at 18, almost like 18.7. Over the age of 85, they're 47.2. That's a large number. Okay. So if you look at the overall the cause of death in the United States, the Alzheimer is the 4th leading cause of death. And if you look at the Framingham studies for the prevalence, that's the same type of thing you are seeing. As the age goes up, the prevalence goes up. So what we see in the genetics, this is what you can do in the blood test. And this gene, ApoE, in the Alzheimer's, people who have late onset, you see this ApoE on chromosome 19, or on the there are another two genes which you can see, A2M and LRP on chromosome 12. If one have those, there is a very high probability of getting the Alzheimer. Or person has this autosomal dominant mutations. Anybody know what mutation mean? Okay. What it is, basically all of us, if we look at the gene, we have proper sequence. Most of us will have the same kind of sequence. But in the mutation, in that person, there is some disturbance in there. Okay. If somebody has this PS1 presenilin on chromosome 14 or PS2 on chromosome 11 or amyloid precursor protein on chromosome 21, you are going to see the early onset of Alzheimer. That's where you see the early onset, where the genetics, where you see these PS1, PS2, and APP, you're going to see early onset.
Are there special tests
There are special tests. Yeah. Actually, one can get it done and then find out. But, many people don't want to, Then you are going to live with a fear, But as we are getting more into the treatment, the earlier diagnosis is much better. So the ApoE4, there are two parts which we're looking. Actually, there are three. Those are APO2, APO3, APO4. If person has a APO4, that's a high probability of getting the Alzheimer. The ApoE2 is a protective one. Okay. If somebody has ApoE2, you are having less of that. So what you see here is, if you have two copies, like APO4, you see how the decline is. And if you have 1,4, 1,3, you still have decline. With 2,4 or 3,3, you still have the decline. 2,3 you still have, but if you are 2,2, then you are less. Right? So that's what you see. So as we are getting into this biomarker, you are looking at the various kind of phase. And those phase 1, you are looking at the entorhinal cortex. That's where you will see some of the impairment. In phase 2, you're going to see in the hippocampus. And hippocampus is where the memory is. Okay. And in phase 3, you have the neocortex, and plus, there is a major impairment in that area. So this is the way, if you look at somebody's brain, you will see this is the area, hippocampus, that's the memory part. Amygdala is the emotional memory part. And this frontal lobe is where the executive functioning is. And that's where you're going to see the impairment, and you're going to start seeing the plaques in there. And if you look at the frontotemporal, the frontotemporal brain, see what happened? And this is the frontal part, this is the temporal part. Okay. And this is what you see in a patient with the Alzheimer's disease. And what you are seeing is, in the past, this is all we knew. The ventricle gets enlarged. There is atrophy, the ventricle gets enlarged. And if you do the MRIs and the scans, CT scans, you see the normal person brain, and you see their ventricles. And if you're looking at the person with the Alzheimer's, you see the enlargement of the ventricle and this atrophy of the brain. And this is what you start to see in there. One is the plaques, and that's where the beta-amyloid, which is formed by the beta protein fibrils, and this is mainly from the AB peptide at the level of 42 amino acids. And it becomes when it becomes, the surrounding area is also swollen, and then you start to see dystrophic neurites. The second part, you start to see these tangles, neurofibrillary tangles. It fills the interior of these neurons. And the presence of the plaques and the tangles at autopsy, that's what is used to confirm the diagnosis of Alzheimer in the past. Then you start to see some inflammation around it. And in this phase, acute phase, you will see the protein in the serum and the plaques, start seeing those cytokines. And the microglia is the inflammatory part which is involved with that. You see cytokine A in levels increase. And then you start degenerating neurites. And the serum cortisol levels is higher in the Alzheimer's disease. And that is a marker for the inflammation. Then amyloid, this is what we are talking about, APP, amyloid precursor protein. And that's what happened in the gene mutations. And this sequence, especially at the level of 42, you start to see impairment. And this is amyloid Beta-42. It's a very sticky, and it's produced from this amyloid precursor protein by this secretase. And mainly we are looking at the gamma secretase. Actually, there are some medication which are being looked at which can block that, and then can block this breakdown of the APP. So then once it starts, it's very sticky. Then it starts to associate together and make it toxic fibrils. And these are insoluble, and it's resistant for the proteolysis. And they get more and more aggregated. It's hard for brain to remove it. And if you look at the diagram, from an artist, this is the way they will become. Beta-amyloid plaques, and that's what you will start to see. But in imaging, this is where we are going. Okay, and you see somebody with a negative scan. You see this one. See there how it lights up, and somebody who has the amyloid deposits. See how it starts to light up on that. So you will see the imaging like that, amyloid imaging.
So even before the onset?
Before the onset, way before the onset. Even before, you start even developing the preclinical. And this is what you will see. This is the normal scan. This is what you are looking at, the hypometabolism. This is second marker we are looking at that. And so somebody who is Alzheimer, see that it didn't show up here, but what it is, you are looking at this, somebody with a normal, but when you look at somebody with abnormal, you won't see something like that. This thing got cut off. Okay. And this is what you do see at the autopsy. You see the plaques, and then you see the tangles in that. This is the histopathological diagnosis. The other one is biological diagnosis. And again, you see the plaques and neurofibrillary tangles like that. And these are the one in the neuron. You will see the tangles in there. This is the tau protein which we talked about. And when it starts to get phosphorylated, it fails to bind. And this filaments, they form tangles. In the axon, the whole transport is blocked and lead to the degeneration. These are the other two we talked about, PS1 and PS2 mutations, and these are transmembrane proteins. And as we see, somebody who has the mutation for that has the early onset of the Alzheimer. So let's stop here for a second. We talked about the diagnosis, we talked about the type, we talked about the prevalence of that, and we talked about the underlying neurobiology. And so let's take a break for a few minutes, and then we can come back and we can talk about it. Thank you. If you look at the different lobes, and if you look at the frontal lobe, this is the area type of thing which we are talking about. And those are like problem solving. These are all executive functioning which we talked about. And then you look at the temporal lobe and the parietal and the occipital lobe. These are various type of functions in different lobes. And we already talked about in a dementia and a major neurocognitive disorder, you're going to see somebody whose onset is very gradual, it's a chronic, it's a progressive, and it's irreversible. Okay? But in some time, the decline is a little bit static, and consciousness is not clouded. And these are the areas we already talked about, the executive functioning. And the people can go through various phases of this, where their abilities will deteriorate. And sometimes it changes from day to day, sometimes it declines slowly. And all these features may not be present in every person. And not every person may go through this stage. And we already talked about the impaired cognition. And not only the cognition is impaired, but it also leads to deterioration in the emotional control. We talked about the social behavior and the motivation of the person change.
There's been some research that's been done on hearing loss having an effect on this as well because of the isolation.
Right.
Is that tying into this also?
That's true. It can. But at the same time, you have to differentiate. It's the receptive language. Even though it may be just a hearing, but if the receptive language is not there, okay. So first you have to, if the hearing test and all that improve, that's good. But sometimes it's the underlying brain, the receptive area of the brain is involved. So then, along with the motor problems and the decline in activities of daily living, okay, even the washing, eating, toileting, all this gets impaired. So when we do screening, we look at all this kind of tests we already talked about in the memory, how the person will register the information, store the information, and then they retrieve the information. In the late stage, even the old material is also lost. Patient may not remember where they were born, when they were born. And you can test these things by giving 3 objects and recalling them, or you can ask them to list the name. And we do screening tests we call mini mental status examination, or we call SLUM. This is St. Louis University mental status exam. And this is in the public domain. The mini mental status at this time is not in the public domain. So you can go to St. Louis University mental status, and that's easy to do. Remember this MA6. So M is the memory impairment. And then you need one of the other things. Apraxia, aphasia, agnosia, abstraction ability impaired, crowding of consciousness is absent, and ability to function is impaired. Anybody knows what apraxia is? Apraxia is you have the intact motor system. There is nothing wrong with their motor system. There is nothing wrong with either the tone or the muscle, but it's the ability to carry out the function is impaired. If you ask somebody to tie the shoelace, they know they are receiving it, but they don't know how to do it. Okay. If you ask them to turn the faucet on, they may not know it. Okay. Inability to carry out the activities, voluntary activities, in spite of the intact muscular functions. Aphasia, anybody know what aphasia is?
You know what the word is, you know what you're trying to describe the word wrong.
Right. It's basically, it's like if you look at the clock, they cannot say clock. They will say time. Okay. So they start to describe the function of that rather than what it is. Okay. Right. It can be the expressive and receptive. And the aphasia is, so sometimes the person will just start saying based on how they are related. Instead of the coat, they may say boat. Okay. And so these are the type of things you will see in the aphasia. Agnosia, anybody know what agnosia is? Inability to recognize. Okay. So if you give them something, you give a coin, they won't know what, they can't even, look at that and won't be able to tell you.
All the time I've worked with these folks, I never had anybody that happened. But they always could identify the
Right. But when you see many dementia patients, right. Right. So agnosia is inability to recognize. Right. Okay. So what it is, you will see in the patient when they might be holding they want to get a fork, but they will be holding the spoon. Okay. They might think it's a comb, but they might be holding a knife. Okay. Because their brain is telling them what they are holding is, what they are seeing is, they are seeing a knife, or they are seeing a comb. Okay. So they can't see the knife, but the comb is what they think, what it is. So that's the way, what that agnosia is. Then ability to abstract and the clouding of absence and ability of function, we already talked about all those. Then person can go through various stages. This is a very early stage, and many times you don't even recognize. When you look back in hindsight, you may see the person had this kind of difficulties. They were indecisive, they were having difficulty adapting to the change, they were taking longer to do the routine job, or they lost the interest in the hobbies. So these are the types you start to see very early on. And it can last anywhere up to 4 years. Okay. So the second stage is intermediate, can last up to 10 years. And that's where the person starts to forget. They forget about the recent events, they get confused one family member with the other, and they forget the name of the friends. They are not taking care of their hygiene, eating or attire. It's very hard for them. And the person may be disoriented. They may get lost, or they miss the social cues, and the risk of fall increase. And the person can be distressed, frustrated, and can have the aggression, restlessness, and the sleep pattern is disorganized. Sundowning is right. It's basically this whole sleep patterns and the circadian rhythm starts to get impaired, and so that's what leads to all that. The late stage is basically a downhill course, and the person is unable to remember even for a few minutes. They lose their ability to understand, and they have no recognition of their friend and family. They cannot even recognize everyday objects. It's basically end-stage dementia, which can lead to the death, coma, death, mainly to the compromise in the immune system. This is where we are going with the criteria for the Alzheimer guidelines. We are looking at the preclinical stage. We are looking at the biomarker stage. Okay. And these biomarkers, as we talked about, they occur years before any disruption in the memory, thinking, or behavior. But, as we talked before, all this specific to the Alzheimer, only as we talked before, there are two parts of that, amyloid imaging and those atrophy or hypometabolism, hypoperfusion. And in the past we called it mild cognitive impairment, which is detectable earlier a little bit, and now we call it a mild neurocognitive disorders. This is where we want to go. This is the preclinical stuff. And the earlier we diagnose, that's where we are looking for the treatment for that. At this time, our treatments are here. Okay. The normal we already talked about from 20 going like this, and then people with dementia going like this. Now with medicines which we are using, which are approved, the evidence-based, they are basically trying to slow it down a little bit. They are not providing any cure. But what we are trying to do is in the research all over the world is looking at this stage. Okay. So let's say we diagnose somebody with the major neurocognitive disorder. So what type of diagnostic workup we're going to do? we are going to exclude other cause of the neurocognitive disorder. We are going to do the cognitive test. That's the only way we look at the domain. We person need neurological workup, may need a EEG or a CT scan or PET scan and SPECT scan. And the autopsy is the only definite, as we talked about. So we are trying to rule out the reversible etiology of dementia. One is the hypothyroidism. Person who has a hypothyroidism, untreated, can have exactly dementia type of picture. Or the person who has a B12 deficiency and folic acid deficiency can have the dementia. And where we look at that, we will check the B12 level or the MMA levels. Anybody know what MMA is? It's methyl methylmalonic acid levels. It's a specific for the vitamin B12. And the HC is the homocysteine level. If you have an elevated level of homocysteine, very high risk of developing the dementia and also a high risk for developing the cardiovascular disorders. And the homocysteine level actually can be lowered by the folic acid. So that's the reason, sometimes you see maybe the folic acid can cut down the risk. Then people with the neurosyphilis or any infections, and we do these tests like ESR, ANA, these are the type of titer we have, and the RP which we look at that. If we have any, then person can be treated for that. And chronic meningitis type of things. May have to have the lumbar puncture for this. That's the thyroid stimulating hormone and the level of thyroxine.
But I guess where I'm confused is I understand what it is. How does it affect it?
It's how it causes the dementia type of picture. It can affect all the attention, concentration, and functioning of the neurons. So that's what you will see.
What was the B12 connection?
B12 is again for the neurons. Remember neuropathies, and when you have low vitamin B12, the person can have neuropathy. Same thing with the neurons, you can have the impairment in that. We already talked about the ApoE, and this is available through the blood test. And if the person has E4, it's almost 100% chance of developing the Alzheimer's. If the patient has E3 and E4, 97%, E2 and E4, 94%. So 4 is the bad part. Okay, and with the E4, the chance of having is very higher, almost 100% with the E4, both copies. In the CSF, we already talked about the amyloid beta. We look at the protein, we look at the tau levels. It's 95% specific for the Alzheimer's disease. And all of us remember President Reagan, and that was the surrogate marker which was looked at there, AD7. And we talked about earlier AD7 levels. So these are basically like a neural thread protein, and you see mostly specificity and specific. It's not specific for Alzheimer's disease, but sensitivity is very high. So we talked about the criteria. So criteria is basically, as we talked about, those cognitive domains on the complaints and the testing. Then we talked about impairment in the activities of daily living. And then we talked about not part of the delirium, not part of any other disorder, with these markers. Okay. So if we have somebody with all that, what kind of treatment we can provide? At this time, there are not many treatments. There are something which person can do as a prevention to slow it down. And the prevention is eating well. Eating well is, the balanced diet and looking at those vitamin B12, folic acid type of levels. Exercise does help, routine exercise program. It's not when somebody had developed dementia. It's doing it daily as we do daily, we delay this.
There's been some mention of coconut and coconut oil.
Yeah, that's part of the eating well. Some of those things have. If you look at these, there are some countries in the world where there's less of it. Okay, and there is a role of the diet. What type of fat diet? No. And if you look at the Southeast Asia or in some part of the Africa, the incidence and the prevalence is less. Okay. So the prevalence is highest in the Western countries. Okay. So there is some role of the diet. Exercise has a role. So basically keeping the mind active. That's what we were talking about, the crossword puzzle. The more the person keep it active, the better it is. And the regular checkup, if it's hypertension, we already talked about that, diabetes. People who have diabetes, they have a very high risk of developing the dementias. And so taking good care of yourself, that is important. Regular checkup is important, screening is important, and then follow through with. So risk assessment, then somebody who has it, then we look at these areas: self-neglect, poor judgment, wandering, abuse, disinhibition, aggression, exploitation by relatives. We have to look at the fitness to drive. A person gets lost. Okay. Or if there's the aggression towards the other. So that's which lead to the interventions. And what is the risk level and where the needs of that person can be served better in that assessment. So the intervention which we do, it's hard as a caregiver, very hard, but providing some clear, calm, and comforting structure and some routine can be helpful. Sometimes changing in the surrounding and people need to be explained in advance. It can be very distressing to the individual. Keeping the room bright and containing some of the sensory stimuli and reinforcing the orientation will help. And regularly engaging in some low stress activities. The more the isolated person is, the worse it is. And sometimes you have to redirect. It's very hard, but you have to redirect with a distraction, substitution. Sometimes it's better. Don't talk about what you want to talk about. You have to listen to that. And if you work with that, sometimes it's better. If somebody remember what happened in 60s, and that's the only thing they want to talk about, having something around 60s will be helpful. Just maybe getting those movies or getting that type of environment can be helpful a little bit. So. Again, it's hard as a caregiver, but more soothing and reassurance type of things do help. Then the treatment-wise, if we're going to talk about only the FDA approved, then we will talk a little bit about what we need to do. The FDA approved medicines are only to work on the memory part. And these medicines we have, they are called choline esterase inhibitors. And so what they do is, if you look at the diagram, these are neurons and neuroreceptors and neurotransmitters. And the way they work is, this is the neuron with acetylcholine. That's the neuron we are looking at. It is destroyed in patients with Alzheimer. But what it does is, as you see, it works on various receptors. It can work on the glutamate receptor. That is also important for the memory. And if you see on dopamine receptors, this acetylcholine work on that. So it's not the destruction of just one, but how it interacts with the other neurons. So the function starts to get impaired. Okay. So when we see the psychotic symptoms, there is a role of the dopamine. The excess of the dopamine as compared to the other can give rise to the hallucination, delusions. So the glutamate receptor is also for the memory. The medicine Namenda, which we have, is approved to act on the glutamate receptors. The medicines Aricept, Exelon, and Raminol they work on this acetylcholine. And so basically what it does, they do not provide any acetylcholine, but they work on the choline esterase inhibitor. So it prevents the breakdown of the acetylcholine. So we'll talk a little bit about these. So these are the medicines. In the beginning, we thought we can just look at the lecithin. It's the L-DOPA dopamine approach. But it doesn't really help as much. Then the first one which came was Tacrine, Cognex. So it is not on the market anymore. It caused the liver problem, but that was the first one. So it was removed from the market. Then we have this Aricept, and that the advantage of this is once a day. Okay. So usually you start with 5 milligram. We have to wait for a few weeks. Then you can go to 10 milligram. Then there is extended tablets available. That can be used. This rivastigmine, Exelon, and that is like comes in like 1.3 milligram, and then you go twice, but it's twice a day. And this glantamine is also twice a day. So all they work on that is acetylcholine, just to increase the level by preventing its breakdown. Then the second part is the glutamatergic drug. That's Namenda. It works on the glutamate receptor. It does not work on the acetylcholine. And it's moderate to severe Alzheimer. The glutamate has a role in the memory. So usually you start with 5 milligram once a day. Then you increase to 10. Then you can go to up to 20. But you have to wait at least a week before to go up on it. And it does not work through the acetylcholine, but it works through the glutamate receptor to help with the memory. So all these medicines which are FDA approved, they work only through this system, either the glutamate system or through the acetylcholine. But the problem you are having is this behavioral disturbance. The problem with the sleep. Remember we talked about sundowner. We talked about the circadian rhythm. That is impaired. None of these medicines are going to make a whole lot of difference in those. And if somebody is psychotic, these are not going to make a difference. But none of the medicine which we use for psychotic symptom is approved in the patients. And actually there are some studies in which the mortality level increased. The mortality is the people who take the antipsychotics in the elderly, their risk of stroke and the risk of the early death increase as compared to the placebo. Okay.
So what do you do?
That's the struggle. So,
I've seen them prescribed.
right.
Yeah.
So we'll talk.
Not my area, so
Right.
I'm saying.
Right. So, but there is, what I'm saying is there is no evidence-based study to guide it. Okay, for those areas. But when you are dealing with a family, dealing with a patient, and you have to do something. And so sometimes it's, there is a desire to do something, but sometimes you may end up causing more harm. Okay. So what we will do is, again, none of this is FDA approved. So I'm going to talk about all this off-label stuff. And that is, the first part is if you can improve somebody's sleeping habits, things sometimes gets better. So what we use for that sleeping habits, the melatonin or Rogerum, that's part of the melatonin system. Same, it works through that, Remeltion. It can correct the circadian rhythm. So in some people, just that can take care of the issue. But in some, it may not be. So that's where we prescribe medicine like Trazodone. Trazodone or Remeron we sometimes use. And the advantage of Remeron sometimes is it increases the appetite a little bit. And it also helps with the depression. Sometimes there is an underlying depression. And if we can treat, we can cut down the other behavioral disturbance. So that is the rationale for that. But if somebody is really psychotic, and those are the persecutory delusions we are talking about, where they are accusing that they are being watched, those kind of symptoms, And what else you can do other than some of the antipsychotics? But if one have to use antipsychotics, need to have a good discussion with the patient family why we think it's important. And many times the family then they are frustrated. They want to do something anyway, right? Or if the person is in the nursing home, the criticism is in the nursing home and the elderly, it's the staffing issues, and we are over medicating it. So that is the criticism, and they actually at the CMS looking at that, they want to cut down it more, the prescription of the antipsychotics in the elderly. And so if one have to use it, very, very low dose to begin with. And because the sensitivity is very, higher, because looking at all these neurons, it may cause more side effects. And if the person has side effects, and the medicine we use to control the side effects, like cogentin type of medicine, Arten, they are anticholinergic. So they cause more problems because we are trying to increase the acetylcholine, but at the same time we are blocking the place where the acetylcholine has to work. Okay? So the low dose of the medication or the some which cause less of the EPS type of symptoms we use, and one of that is Seroquel. The Seroquel, it doesn't cause as much of the tremors and the rigidity and the low dose type of thing which we work with. But so that is all off-label. I need to have a good discussion. But all these medicines, as you might be aware, they can cause metabolic syndrome. And the metabolic syndrome is, the risk is increased, and that is the increase in the lipids and the blood sugar. Those things need to be monitored and watched. So that, but especially in the patient with dementia with the Lewy bodies, the Parkinsonism type of symptom gets worse. So it can cause more problem with that. But again, something like Seroquel, which has less of that, that's the reason sometimes you will see more of that type of medication. And so sometimes you see maybe Zyprexa type of medication. But the medicine like Haldol, Risperdal, sometimes will cause EPS type of symptoms. And then you have to use something else.
What kind of dosage on the melatonin?
And melatonin, usually you start with a low dose. You can go maybe up to 3 milligrams, something like that, and then going higher to that. If you're not getting any benefit at 9 milligrams, you're not going to get a whole lot of benefit. Right. So that's what you'll see. So then if somebody is depressed, giving some antidepressant does help. And one of them, Remeron, can help with the sleep, appetite, and the weight type of issues. Then if you give any of these medicines, these are like Aricept, Exelon, Reminol. These are the type of side effects you see. And you see like nausea, vomiting, diarrhea. And that's the reason we go very slowly. We don't increase it rapidly. So what's coming on the horizon? There are many compounds which are acting on multiple sites. And they're like cholinergic agents. They may improve the function, but may not help with the disease process. There are the dramatic result sometimes we are seeing is with this AMPA kinase. This AMPA receptor is basically like this glutamate. Glutamate is NMDA receptor, and the AMPA receptor and the kainate receptor. Those are the three in the glutamate system. So the AMPA receptor, positive allosteric modulator, they improve the performance in normal 2 to 3-fold. It's a highly investigational, but that's the direction we are going. The other one is, remember we talked about the nicotine receptor on nicotine receptor number 7, and that there is ongoing investigational drugs for that. And sometimes we prescribe anti-inflammatory agents. That's Indocin is being looked at that. Motrin was looked at that. So to reduce the inflammatory cytokines. There are ongoing trials. and even the aspirin is being looked at that. Remember this vaccine? There is still ongoing research on that. And this is actually, if we can find a vaccine, and the people who have those ApoE4, if you give it early on, it can prevent the formation of the plaques. And it can be helpful. And even if somebody has it, like in the mice, and it can make the plaques regress. So there are clinical trials ongoing. It has safety, tolerability in the human, and looking at the efficacy on those. Because this has to be followed for many years. Because these are the people who may have it but may not develop it for many years. Still ongoing in the horizon further on, there is gene therapy being looked at. Remember those 4 we talked about, APP, PS1, PS2, and the ApoE4, and that is giving replacement for gene. And then secretase we talked about, gamma secretase inhibitor, and that can prevent the breakdown of that. And so other means of amyloid clearance is being looked at then. There is one study which just came on, and it used ultrasound technology to break those neurotoxic amyloid plaques. It's an interesting study. What it does is it breaks it down, then it opens the blood-brain barrier to remove those plaques. So it's an investigational study, but it is on the horizon. So there are various kind of things which are in the pipeline and which is coming. So I know it was a lot of stuff in a short time, and so we covered all that. So any questions? Yep.
What's the connection, if any, with chronic stress?
With the stress?
With chronic stress.
Chronic stress.
Leading to dementia? And if so,
Right.
then what age?
Chronic stress from even early age. Remember the hypothalamic pituitary adrenal axis? The chronic stress will raise the level of the cortisol. If the cortisol level is increased persistently, it will cause the shrinkage of the hippocampus. And that is not good at all. And the volume of the hippocampus decreases, and it affects the memory and all that type of stuff. Actually, there are studies in the children who there is a history of physical, emotional, sexual abuse, and you follow them. If you don't treat them early on, their hippocampus shrink, and it causes a problem in that area. So chronic stress can lead to that. There are studies in depression, people who have major depression, their risk for dementia increase considerably if the depression is not treated. So the depression is a serious thing. It needs to be treated. Same thing, chronic stress is a serious thing.
What I'm thinking of is many of the people coming back from in the military, the PTSD would increase the cortisol levels, would increase some of those other issues. And so that, if I'm tracking with you, you're saying they're at a greater risk for dementia.
Right, they are. And some of you might be here when I did a presentation on PTSD. And there is a lot of research on the PTSD. There are some studies came even since I did the talk last time on the PTSD. There are chemicals looked at. One is the vaccine being looked at that on the ghrelin. Ghrelin is a chemical which is formed in the stomach, in the fundus of stomach. All of us have it every day. In the stress, it increases considerably. If it rises considerably, it increases the chances of PTSD. So there is a vaccine which is being looked at that, and so that can prevent it. There is controversy that you are going to give it to soldiers who are going to combat the vaccine, which can prevent it. So there is another substance called NPY protein. You can look at that. There are studies on that. If the person has a high level of NPY, this is neuropeptide protein, and they have a less chance of developing the PTSD. The people whose levels are low, they have a very high chance of developing the PTSD. So there are some studies on those. So it is basically working with the people who have the significant anxiety disorder, PTSD, significant depression, chronic stress. They need to be treated early on and aggressively.
I work with the military, and I'm wondering, with the high rate of PTSD and TBI, if there's really going to be a significant increase in Alzheimer's diagnosis.
Not Alzheimer's, dementia. Major Alzheimer's is a totally different thing. TBI and the PTSD, these are the things which we are talking about, can give rise to the neurocognitive disorder. And we will say neurocognitive disorder, major or mild, due to TBI. So it's the Alzheimer's is a totally different thing. So this part, we have talked mainly Alzheimer's. If you will have interest sometime in the future, we can talk about the other TBIs and the other thing. But those are the type of things which there is a lot of research going on, many studies, and going forward we're going to hear more about.
So are there any studies currently being done, the effect of certain kinds of diets as related to the later development of dementia or not? For example,
there are. If you look at the certain population in the world, you look on certain islands in Mediterranean, you will see less of it. Okay. So you see in South Asia, you see less of it. You see in some part of the Africa, people are getting old. They are like in 90, 100. Their risk of Alzheimer's is less. So it is part. It's not that their education is any better many times. Many times it's just the diet, the role of diet and that.
Has there been, to take this a step further, any kind of protocol for a diet for people who are at risk of having increased dementia to decrease or slow down? Or, like, for example, if you know that eating glutens is going to cause you a problem, or eating excess sugar, is that something that they are looking at now to create a protocol for diet?
Basically the best thing is, remember we used to have pyramid, and now we have a plate, right? So it's basically, it's in that plate what we put in that. And again, is that carbohydrate better than the fat, or is that protein? So, right. So looking at those kind of things, there is a study going on. Okay. I know you have some patients to go and see, and so thanks for coming. Thanks for coming. Thank you.